Don't wait any longer. Take that person to the hospital, because that's getting way up there. That you can have a lot of complications happening after that. Okay. So history and physical examination. The chest X-ray is a common test, very common. And what we see, the chest X-ray, we can see if the heart's enlarged, but it's still not an accurate way of saying it. But also in the chest X-ray, we can see if there's fluid in the lung. If there's fluid in the lung. I just want to raise this caveat here, is that fluid in the lung is a very common symptom. It's a common finding on chest X-ray. But I'd like to raise this issue here. Sometimes pneumonia can appear like heart failure on X-ray. So if you have a chest X-ray, they tell you, oh, you may have a pneumonia. Ask them, is it pneumonia or heart failure? Because they can look very similar sometimes on chest X-ray. Just a caveat. So the purpose, like for us physicians, is by getting the history, by getting the physical, we put things together. Hey, you put the story of the patient and the X-ray together. It sounds more like heart failure. He's short of breath. He can't lay down, and he has this patch, fluid in the lungs. Remember, X-rays are just shadows, white and black, basically. So the white fluid will look like white. Whereas in pneumonia, they'll present, they have fever, chills, they have cough, and then they have, and then when they cough, it hurts to cough. They have pleurisy. That's more pneumonia-like presentation. So you put the history and the chest X-ray together to come up with the diagnosis. But I just wanted to make that clear that, because I see this quite often, patient has heart failure, and again, I'm not trying to fault any other. Or remember, sometimes radiology, when they read it, they don't have clinical information. They'll just see the spot in the lung. By and large, it might be a pneumonia. So they don't have the clinical information that your clinician has. So I always like to put things together, Then the other is a blood test. We do blood tests to see if your kidney function is working well. Because if you are in dialysis or having kidney failure, since the kidneys are not working well, what's the job of the kidney? Is to filter the blood and get rid of the fluid. If the kidneys are not working well, what happens? You retain fluid. So you can have a totally normal heart, but you're not getting rid of the fluid, so you can still be in congestive heart failure. Not because of the heart, but because the kidney is not getting rid of the fluid. Okay, does that make sense? I just want to make that concept also clear. So that's why in the blood test, we always look at the kidneys, we look at the electrolytes, we look at blood test if you had a heart attack. Troponin levels are a good marker of a heart attack. So if the patient had a heart attack, then they can have heart failure also. We also look at some what we call biomarkers. So these are more recent blood tests, like a BNP, brain active peptide, which if elevated, is usually elevated in the setting of congestive heart failure also. Okay, so it's a new biomarker. It's a blood test which suggests that if it's elevated, there's a big chance you have congestive heart failure. The only caveat, like I said, is in renal failure. If you have kidney failure, your BNP will always be elevated, even though if you're euvolemic or anything. So patients on hemodialysis, their BNPs will always be high. On hemodialysis, they're in end-stage renal disease. Again, the heart and the lungs and the kidneys are the three organs that work together. Heart, lung, and kidneys. Very crucial. Very crucial for life, very crucial for survival. The other one is electrocardiogram. We look at the EKG. What does the EKG tell us? It tells us if you had a heart attack. It can tell a scar, an old heart attack, or a recent heart attack. So because if you had a heart attack, your heart muscles could have died during the heart attack, which could have caused weak heart muscles. And so you're prone to heart failure also. Okay? Also, the EKG will tell us if you're out of rhythm. Remember how I said atrial fibrillation? Atrial fibrillation means the atrium, remember our anatomy earlier, the atrium, the left and right atrium, the top chambers are just, normally the top and the bottom chambers are pumping in synchrony. And again, I apologize, I had some video, but can't show it here, it's not working well. So, and if it doesn't pump in synchrony, we automatically lose about 15 to 20% of our cardiac output. In other words, what the heart pumps drop by 15 to 20% when you lose the synchrony of the atrial fibrillation. And so normally you can handle that. Your heart rate is 50, 60, 70s, 80s, 90s, up to 100, even up to 110 beats per minute. Sometimes you can handle the fast heart rate. But when your heart is out of rhythm and it's very fast, 130, 140, you will get short of breath. You can get dizzy, you can get lightheaded, and you can even pass out if it gets too lightheaded. Because at that point, the blood pressure can start to drop also. So my point is, if your heart is out of rhythm, yes, you want to know, because yes, it can cause heart failure also. Okay? Then the most common tool is what we call the echocardiogram. The echocardiogram, from the word echo, is from ultrasound. So it's an echo is an ultrasound of the heart. Cardiogram, echocardiograph. So it's an ultrasound of the heart, and then you can see it's like what we saw earlier, except it's an ultrasound wave, so it's black and white. You can see the heart muscles pumping, and you can see the heart valves working. So you can tell, number one, if the heart size is normal. Number two, you can tell if the heart is pumping normally. You get the ejection fraction. That's how we get the ejection fraction more commonly. It's from the echocardiogram, the ultrasound of the heart. And then we can also get echocardiogram, and then we can get the valves. That's another source of heart failure. If your heart valves are not working, remember I showed you the tricuspid valve, the pulmonic valve, the aortic valve, and the mitral valve. The four chambers are divided by valves. If those valves are not working, they can stop out. If they're stopped out, today I had a lady. She had actually about to do her later on. A very high risk lady. Her valves are not opening. She had her valve surgery in 1995 in Florida, and now it's not working anymore. And then her other valve is not working too. So she'll need 2 valve surgery, redo, which is a very high risk procedure. But the point is, when the valve is not opening well, it prevents the blood from going forward. So I like you to think of heart valves as like the door. Let's say, there's an alarm, fire alarm. So we all have to exit through that door. But what if the door is only half the door is open and the other half is not open? It backs up the line and everything, right? We don't go out as fast as we could because you only have a small hole. Only 1 or 2 people can go. If you have all doors open, you have 4 or 5 at a time can go out of the door. Well, the same thing is in your heart valve. Your heart valve is like a door. It allows blood to go in one direction. That's the main function of the heart valve. And if that heart valve is not working well, either it's not opening well, or if it's leaking, then the fluid starts to shift. And my example is like the door not opening well, the line will back up all the way to the back of the room. Or another example is if the interstate, the aortic valve is like the opening to the interstate, because the aorta is like your interstate. If you have, if your opening to the interstate is only one lane and everybody wants to go, the line backs up, and over time the line backs up from 120 from if you're going to exit at 117, the cars will back up to 127 north, 127 south, initially in Cracker Barrel, then all the way, as the line gets longer, it will back up all the way to downtown Crossville. It's the same thing, except it's blood. The blood backs out because the valve is not allowing blood to go through. Okay? I just wanted to present that concepts to you so you can understand, and how, because of the backing up of the fluid, it did back up into your lung, and you start fluid accumulation in your lung, and if there's fluid in your lung, you can't get enough oxygen because it's like you're flooding. Your lungs are flooded with fluid, so you can't extract. The alveoli where you extract oxygen is flooded with fluid, so you can't get as much air into it. And that's why you said, you're smothering because you're literally, drowning in fluid in your lungs because you're not getting, and then the consequence is you're not going to get enough oxygen in your blood. So now the other one is the exercise stress test. We do that also to find out if there's a lot of information in the exercise stress test. The most common reason we do exercise stress test is to see if you have any coronary artery disease or ischemic heart disease. Remember how I said, the most common cause of heart failure is clogged arteries. And one of the ways to diagnose clogged arteries is doing a stress test. Remember I said the number one cause of death in the country is clogged arteries, coronary artery disease. And the way to diagnose it non-invasively is to do a stress test. Also, we get a lot of information in the stress test. You know, we have what we call the Duke's criteria. It tells us, that, you see, the longer you walk on the treadmill, it's a good sign, actually, in the Bruce protocol. In fact, this is from the Seattle study. This is from the military. They did stress tests on men, although it's biased to men because it was a military study, the Seattle study. Over 10,000 people, they did a treadmill stress test on them, you know. The longer you walk, the higher, the better it is for you. In fact, if you can walk over 10 minutes in the Bruce protocol, your chances of being alive next year is over 90%. Now, we won't guarantee that you won't have a heart attack, but the fact that you're extremely fit, that you can walk 10 minutes in the Bruce protocol, means even if you have a heart attack, your chances of surviving the heart attack is very high, because you may have collaterals already and all that stuff. Your muscles are so trained. And we will go to that topic later on about exercise stress testing. But anyway, the point is that's how we diagnose ischemic heart disease, which is the number one cause of heart failure also. Plus, and so if you can only walk also, in the stress test, if you can only walk 1 or 2 or 3 minutes on the Bruce protocol, the corollary is also true. It's a bad sign. It's a bad sign. You know, because you're extremely out of shape, you're short of breath. When it's from the heart, from the lungs, you know, that can make you short of breath. And also in exercise stress is used also in cardiopulmonary exercise testing when we want to differentiate between heart and lung problems, because they work together. Heart and lung will present, heart failure and lung problems like COPD will present with both shortness of breath. Sometimes how do you distinguish between the two? We call it, we do an exercise stress testing with oxygen consumption. There's some other sophisticated ways of doing it, but that's a way of stratifying patients also. The other diagnostic tests are what we call the radionuclide ventriculography. It's called the MUGA scan, you know, multiple gated acquisition scan. It's a nuclear medicine scan. It was more common before because now we just use mostly the echocardiogram. It's quick, there's no radiation. This one, they inject a radioisotope and it tags the red blood cells. It goes into the left ventricle and it actually measures how much radiation is during diastole and then during systole. It technically gives some relatively more, you know, it gives an accurate ejection fraction. The one who like to use this PEEP are mostly the cancer doctors. Sometimes the cancer doctors, because they like to check the ejection fraction as they give chemotherapy and the heart muscles are getting weaker. They used to do that a lot more before, but now we're using echoes to follow the patient because it's a lot easier and quicker. No need to put an IV in and all that stuff. Cardiac catheterization is another way of evaluating, diagnosing heart failure. Actually, it is the what we call the gold standard for diagnosing coronary artery disease. Because with cardiac catheterization, we get a lot of information. First and foremost, we find out if you have any clogged arteries. That is the gold standard for finding if you have any clogging of your arteries. Cardiac catheterization. We inject it, goes to the groin or goes to the wrist, put a catheter, inject the dye, and as we inject the dye, we take pictures to see if there's any poor circulation to the muscles, you know. And then what also we get in cardiac catheterization, we get the pressures. We get your systolic pressures, and we get the pressure inside the heart. Now in cardiac catheterization, we do a left heart cath and a right heart catheterization. A right heart cath is when we put a catheter, balloon tip catheter on the right side of the heart. So we can measure the pressures also not only on the left side, but on the right side of the heart, meaning the right atrium, the right ventricle, and more importantly, the pulmonary artery. We measure the pressure inside the lung. Okay? So that's another way to go. Okay? But it is the gold standard. And then in the heart failure preserved ejection fraction, we actually measure the filling pressures of the right atrium, right ventricle, right atrium. It's a more sophisticated test, but we can get pressures, the filling pressures of the heart. If the filling pressures are elevated, that is the gold standard for saying you're in heart failure, because the pressure is building up inside the heart chamber itself. So we measure all the actual pressure measurements by putting a catheter in the heart. Now MRI, magnetic resonance, is another way of measuring, and that's, we do that